Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Good evening. Welcome to The Pulse, where we bring real conversations with trusted physicians to inform, engage, and connect with people, patients, friends, and the communities we serve. In this episode, The Pulse on Health Policy, Understanding the Past to Lead What's Next. We break down what health policy really means in everyday life, especially as extreme policy changes are happening almost daily. These decisions affect how we access care, afford medications, protect public health, and navigate through the healthcare system. So let's get started with how we often, without realizing it, we will connect the dots between past policy decisions and what people are experiencing right now. Explain how today's fast-moving policy shifts may shape healthcare in the future, and share why understanding these issues matter for patients, families, and those who care for them. This conversation is designed to meet you where you are, offer clarity you can use today, and empower you to stay informed, ask better questions, and advocate for your health and well-being in an increasingly uncertain healthcare landscape. So today, we are excited to have as our distinguished guest the knowledgeable, dynamic, and charismatic personality of Dr. Dorothy M. Russ, Esquire, who is a community servant with a passion for educating and inspiring the public on a host of topics. She's a graduate of the University of South Florida, the University of Florida Levin College of Law, and HBCU alumni from the Harry Medical College. And she completed her family medicine residency at the Mayo Clinic in Florida and completed her executive master in public health degree in health policy and management at Columbia University. Throughout her career, she has demonstrated a commitment to vulnerable and underserved communities. She is licensed in 20 states. I said 20 states. She is an enthusiastic member of several organizations, including Delta Sigma Theta Sorority, Mensa, the League of Women Voters, the Urban League, the National Council of Negro Women, and the Junior League. In her spare time, I don't know how she gets that, but she enjoys reading, traveling, and writing. She is the proud wife of Reverend Alton McGriff and a loving mother to 3 darling children, AZ, Alton, and Grace. Welcome, Dr. Russ.
Thank you so much for having me. I am looking forward to this conversation and making sure that people know what's going on and how they can make decisions that will best suit them.
Great. So to kick us off, here are some startling facts. The proportion of the population not covered by any healthcare services decreased by about 20% between 2000 and 2023, indicating that in 2023, about 4.6 billion people worldwide were not fully covered. In 2022 alone, 2.1 billion people faced financial hardship, including 1.6 billion people living in poverty or pushed deeper into poverty due to out-of-pocket health expenses. This equates to 26% of the population, and that's a drop of 34% in 2000. The high healthcare costs in the US have been tremendous. Affordability crisis has created and is rooted in the economic issues and recent developments affecting daily necessities, long-term expenses like housing and healthcare. Medical debt is concentrated among the sickest and the most socially disadvantaged populations, often leading to devastating financial and health consequences. And we know that policy reforms like the Affordable Care Act and the Inflation Reduction Act were meant to improve the healthcare affordability and alleviate the debt, but challenges remain. Racial disparities has been affecting more of our minority population in the southern part, the rural countries, Black and Hispanic, and it contributes more to the racial wealth gap, limiting economic mobility. These factors contribute to financial difficulties faced by many Americans, highlighting the need for continued efforts to address healthcare affordability and to reduce medical debt. The next chart shows you the countries that have free or universal health insurance. Among these countries, the United Kingdom, Canada, Sweden, Norway, Australia, Germany, Brazil, and South Korea. There are some 60 other countries that have some type of universal health coverage according to the World Health Organization standards. This is key, and unfortunately, the United States stands as an outlier with regard to having universal health insurance. So to further unpack this critical healthcare issue, let's probe the vast knowledge base of Dr. Russ. And we know, Dr. Russ, that the healthcare costs have been tremendous in the United States. It's created a major issue with regard to people being able to decide about buying a house, living that American dream. And so we want to hear from you about why in the United States is health insurance an employment benefit, and why is it factored around that rather than having universal health insurance?
Absolutely. I think any policy discussion in America has to start with, why is my health insurance related to my employment? What we know is that in World War II, they had wage caps. So different employers were limited in how much they could actually pay prospective employees. So what they could do was offer a variety of benefits. And at that time, health insurance was not that costly, and it became a unique perk that different employers could ask or could offer. So if you had two excellent candidates that were deciding between two jobs, for them, that insurance might have been the deciding factor. And again, when it didn't cost that much, it was great for companies to be able to offer it. However, as time progressed and between tort malpractice laws, defensive medicine, new technologies, hospital administrative cost, the cost of healthcare insurance exploded. And then it became, well, how do we do cost containment measures? But again, in the United States, healthcare is tied to employment because of a quirk of World War II and being able to have competitor employers be competitive.
So what happens to an individual when they lose their job or they change jobs?
Absolutely. And as someone that has had a variety of jobs, I know this all too well. There's the safety net of COBRA, which out of pocket is very expensive. So sometimes people will be able to go on COBRA, which provides benefits. You have to pay out of pocket for your healthcare coverage, and you have several months that you have that option. Sometimes people will be on their partner's insurance. Now with the Affordable Care Act, there is the marketplace insurance. And then unfortunately, sometimes people do decline coverage altogether, or they find a high deductible catastrophic plan, or the new, well, not new, but a very popular format of healthcare delivery now is direct primary care. And I know we'll talk about that a little bit later, which direct primary care coupled with a high deductible catastrophic plan is an option. But again, it shifts the focus on, well, now I've lost my job, or for whatever reason, separated from my job, and need to focus on what I need to do for my family, to how am I going to make sure that my family still has coverage while navigating trying to find employment again.
And there are some pundits who believe that healthcare costs across the United States would decrease if we went back to our normal system of the relationship between the doctor and the patient. What has created such a hardship for the healthcare industry by putting this third party in between the patient and the doctor?
Absolutely. So it's multifactorial. 100 years ago, you would have gone to your doctor, or your doctor would have made a house call. I think it's almost circular how with telemedicine and during COVID, how that exploded. We were actually able to go virtually into our patients' homes and offer that benefit. But once you add a third party in, you have a conflict of interest, for lack of a better word. So you have this third party that is trying to provide cost containing measures because they're looking at a large population. That's why we have these population metrics, or basically what doctors are graded on, especially in primary care. Are you ordering this vaccine? Have you done this study? Which are all necessary and should be done, but any board certified physician or physician that's practiced will be able to do that without this additional layer of oversight. But you have the insurance company trying to do cost containment measures. And sometimes, as we've all experienced, saying your doctor said you need this medication, the pharmacy says you need this medication, but we're not going to give it to you, or you can pay out of pocket. And again, that becomes, oh, if I'm paying these premiums, if I'm also contributing, if I have this deductible that's $10,000, what is the insurance company really paying for? And again, when you look at the population, they're providing coverage for thousands, millions of people. So the other thing that's very important to note in health policy and insurance is that you have to have a certain number of users that will not use the service that much. They may get a preventative screen. They may need to see one specialist a year to offset the patients that are going to be high or super utilizers that are going to be seeing a variety of specialists, needing a variety of studies and procedures. So you have to have people that are paying into the system, but not requiring a lot out to compensate for those that will need a lot of not extra care, but a lot of care. And people, you never know what situation you might find yourself or a loved one in. So if the care is there and you need it, by all means, get it. But in order for insurance to work, you have to have a subset of the population that doesn't need it. And if those people are pulled out, and this was what panicked people when there were issues of these super high skyrocketing premiums with the Affordable Care Act and the subsidies not being renewed. If you have people that you're like, I only go to the doctor once, maybe once every year, once every other year, I'm not going to pay it, figure it out. Then you have the system now trying to cover the same amount of super utilizers, high utilizers with this decreased portion of input. So less money in, still requiring the same money out. And then on top of that, not only do you have the insurance companies struggling, then you have hospital systems who they get their payment again also from insurance companies and from government contracts. And if they're not getting the money in, especially safety net hospitals, which I've worked at several, and they do serve a purpose in our communities. But if they're not getting the money, then you start shutting down labor and delivery floors. Then you start creating health deserts. Then you start reducing access. And then we all suffer, because if there's no hospital when you have an emergency at 3:00 in the morning, it doesn't matter what your insurance is, how good it is. If you have the Cadillac plan, if there's no hospital for you to go to, or physician or provider team to provide the care, then it's as if you don't have care. So again, having insurance, which is great if you need it, which most of us do, doesn't also guarantee that you get care. It all works together as a system.
And it sounds like you're talking about different levels of care, even within the structure of the health plan. If I'm a patient and I'm going from the fortunate status of one job to another job that has health insurance, shouldn't I or wouldn't I be getting the same type of benefits of care?
Oh, that's a great question. So with the Affordable Care Act, it did dictate certain requirements that each plan had to offer. You have to have a wellness visit, which I don't even like to say wellness exam, because technically it's not a physical exam. It's a conversation to make sure you've had your preventative screenings. The second your stethoscope comes out, it becomes an exam, and then it's a different level of visit. So there are certain screenings that are covered: mammogram, cervical cancer screenings, colon cancer screenings. Can't even say colonoscopy anymore, because we do have different ways of screening for colon cancer. But the issue is, and what I learned, and it was just kind of interested, but also simultaneously horrified by, is even if I have a Blue Cross Blue Shield card from one employer and a Blue Cross Blue Shield card from another employer, it doesn't even necessarily mean it's the same Blue Cross Blue Shield. What certain employers will do is they'll self-insure. So they'll use the insurance company to administer the benefits, but they actually choose their plan. And so it goes back to that, well, why is healthcare tied to your job? I know I had one job where there was one plan. Everybody was on the same plan if you chose to use that company's insurance. And it was decent insurance. It wasn't great. It wasn't the worst, but it was decent, versus somebody else that had a same card by that same company. I won't name the insurance company, so I'm sorry for naming Blue Cross Blue Shield earlier, but this other company that didn't have that name, because those were the benefits that my employer chose to offer. And then it becomes, and this is why it becomes a social justice issue as well. Well, if I have a certain employee base that requires certain tests or may need certain medications, am I going to provide those if they cost more? For example, HIV/AIDS medications is the classic example. There have been court cases about whether employers have to cover those. And again, and this is just out of my own personal thing, we have medication that can literally save lives, that we have seen that a disease that was once a death sentence that can now become a chronic disease and people can live essentially normal lives. For me, it's criminal not to provide that coverage. But having said that, I don't make the laws. I try to influence the voters to vote for the people that will make the laws that best suit us.
Right, right. So if you were designing a healthcare system today from scratch, would you tie the healthcare system to employment at all?
I would offer employer-based insurance as an option, but I would ensure that there was a national safety net plan. And I think one of the big things that I like for people to know is that I know people need a phrase to say, so Medicare for all, Medicare for all. I think saying universal coverage, national-based plans is better language to use, because even with Medicare, the traditional Medicare plan, that's an 80% plan with a 20% copay deductible. So if you're having $100,000 hospital visit or not hospital visit, but hospital stay procedures, that 20% is now $20,000. So if you're just saying Medicare for all without knowing what Medicare is or how you need supplemental insurance or how you need Part C and Part D, and you need to make sure you're not in the donut hole, because I have patients right now that are like, I'm not getting my insulin, I can't afford it. And I'm like, we're going to figure something out, because yes, you are. It's not just enough to know the words to say that. You have to be, and that's why I'm so thankful for this platform and for what you all do. You have to be educated to influence your legislators to say, okay, come up with something else. We need a better plan. We do need a safety net insurance for the country. There's no doubt about that. But yeah, if an employer wants to offer an additional plan, there's no problem with that either, as long as there's a safety net baseline. But when you take that safety net baseline away, then we again end up in that spiral where we all suffer if people pull out.
Great, great, great. And I think it's important for our audience to understand that when Medicaid and Medicare was a legislative option, most of the other major organizations were against having any type of safety net insurance plan. And it was the National Medical Association and the state chapters like the Georgia State Medical Association that pushed the administration of the time to say that this is one of the inalienable rights that our citizens should have. And so we pushed to the point that we were not in the grace of many of the legislators, but for good fortune, Medicare and Medicaid did pass. And as you see over the many years, it has been a boon for at least making a dent in the healthcare, not only for people of color, but for urban communities, rural communities, the poor, the disabled, children, and maternity care. And so we need some type of push again at this particular point, and that comes in the form of health policy. So when we talk about health policy, what does that actually mean to everyday people?
So health policy is realizing that you can make every decision that's beneficial for your health, but understanding you live in a system, you live in a world where there are outside factors that will affect how healthy you are. We talk about the zip code that a child is born into can determine theoretically their life expectancy based on what we refer to as social determinants of health. If I am somewhere where I cannot access healthy food and I go to a corner store or bodega, sorry, I just learned they're the same thing. If I go to a corner store and I'm limited on what I can get, that is a social determinant of health. Health literacy is a social determinant of health. So if I have a city where 50% of the adults are illiterate, before you even add on health information, if they can't understand basic literary foundation, that will limit them. And then when you add on medical jargon or how to take your prescription or why you need this study or why vaccines are safe and effective, that will be another barrier. And the same thing with if we have cities where people can't walk safely, whether it be because of violence or because of their the way the roads are actually situated, those are limiting their ability to be physically fit. So when we talk about policy, it's the coming together to make decisions that are beneficial. The issue is people have their own sides, their own information, their own biases about what is beneficial, and you bring who you are wherever you go. So I might bring the experience of I grew up with a father who was in the military. So I received amazing care through military medicine. And when I got out of that system and had to navigate regular medicine, I was like, but why isn't everything in the same building? I don't understand. Why do I have to go here for labs? Or if it's the college student who was on their parents' insurance, and when I was in college, we got kicked off at 23, but now it's 26, which is great. I'm happy for that. Navigating that system on their own for the first time. Learning how to be an advocate for your health doesn't just mean, okay, now I'm going to do what I need to do for myself. It means ensuring there are policies, there's legislation that allows for the system to work beneficially for everyone.
So why do people feel so disconnected from policy if it affects their day-to-day life?
People, it is my experience, there's big marketing for presidential elections. We might treat it as a sport. My team won, your team won, versus realizing that the people that make the decisions that affect you on a day-to-day basis are your county commissioners, your city council members, your state legislators. And without knowing how those decisions affect you, I think an excellent example is education and whether or not I'm in Florida, so whether or not there are certain books our students are able to access. That's where that policy information comes. And once you help people to understand how your day-to-day life is affected at these different levels, whether it's the judges who are appointed, or the other really obvious example is, for a lot of times, if they're family law cases, the judges that are appointed that might make a custody decision or might finalize a divorce with certain provisions or not having certain provisions. When you realize that these elected officials and officials that are appointed by said elected officials are the ones who are pulling these invisible strings in your life, you begin to see it. If you just hear the term health policy, you're like, I don't study that. I'm over here doing my thing. But once you understand that policy of all types, but especially health policy, affects your day-to-day life, I don't think there's any more intimate relationship than your health. That is your physical body. And once you know how to influence those people that make those decisions, it almost becomes a clarion call and a compulsion to get involved.
And we see a lot of people, want the federal government to stay out of their decision making and their healthcare decisions. But we've seen over the last 6 months in particular, health policy decisions at the federal level that can have major impact on the health, not only for our communities, but the nation. You want to share some of those policy decisions that have come out recently?
So one of the biggest was the Affordable Care Act and whether or not subsidies were going to be renewed in terms of insurance. So Marketplace or Affordable Care Act insurance is great. There are standards that these plans have to have, and you can get them without being tied to a job. So if for whatever reason you're not currently working, you're moving, you don't lose your healthcare coverage. So that's great. The issue is that the amount that you pay in was based on your income. So if you were at a certain income level, you might not get any kind of subsidy or additional payment put in. Or if your income was lower and you needed help, you could still get this really great plan just at a reduced cost. Well, when there was talk of, and again, if we remember, I can't believe it's been 2 months already, the government shutdown, it was over these subsidies and whether or not they were going to be provided. And it wasn't renewed. And now they're in discussions and there was legislation going back and forth last week. And it's January and it already feels like it should be August because of how much has happened on a national level. But it's debating whether or not you're going to renew the subsidies. If you take away the subsidies, and if you take away the scale of the Affordable Care Act, it falls not because it's a bad policy, not because it's bad legislation, but because it simply can't afford itself. And that goes back to when we were saying you have to have a certain number of healthy people in the system contributing to offset those super utilizers. People that need insurance, people that have really chronic health diseases or rare diseases will find a way to get the insurance. But insurance only works if everyone is putting into it. I know I was actually in medical school when the Affordable Care Act was up for passage, and we had to argue pro and con. And one of the things was, why are we going to get the federal government involved? Traditionally, if you look at the Constitution, health is one of those areas that is reserved to the states. That's why I have 20 licenses and not just one national license. And I get information from the different states, and it's so vastly different. And I'm actually glad that I get to see different sides and ways information is distributed. So looking at that frame, there was an argument for why this should no longer be why it shouldn't be a federal issue. But if you look at funding, if you look at the amount of money that healthcare consumes as part of our gross domestic product, you understand that it is a national issue. Whether or not you want to argue semantics, the amount of money put into healthcare makes it a national issue. And then without any other thing, if there was ever any debate, if we remember to 6 years ago when there was a pandemic, it was definitely a national issue, whether it be having embargoes on different organizations being able to get masks in. And then again, I was in Florida, so our beaches opened up within 4 weeks, and I was ridiculed in my MPH class, which was held out of New York. And they were like, "What do you mean you're at the beach?" I'm not at the beach. My city people are at the beach. I'm at home wrapped up, acting like it's 1400, and I'm pulling all the windows down. But I say all of that to say, healthcare is a national issue. It affects us all. And once you understand that I can't make a bridge, I can't make a vaccine, it requires the input of policymakers, educators, the NIH, the CDC working together, healthcare does become a national issue.
And we've seen recently, as you talk about vaccines, we've seen national policy changes in terms of vaccine. Just last week, the dietary guidelines for Americans was released. We've seen health policy with regard to whether states are going to be able to do the Medicaid option so that they can lower the cost to their citizens. And we've also seen a policy coming out even about access to basic services for women's health care. How can individuals see themselves as stakeholders in health policy, not just recipients of health care?
So I think it's all about taking that ownership and realizing that if I make every decision that I know based on current research that's to drive my health, there are still outside factors, and learning that with those outside factors, if I have any influence, now is the time to speak on them. So I think we'll talk about the classic example of vaccines. Vaccines work when a certain number of people have gotten them. So again, if you're able to get your vaccines, and I have soon to be 4-year-old twins that I'm very thankful they're going to make that cutoff of being able to get it in the 2026 year, but I worry about the kids that they'll be in school with that don't get them. Or if you have a child that for whatever reason can't receive vaccines, the herd immunity, everyone else having it is supposed to protect them. So realizing it's not just about you. So you have to find your why. Is the why because I want my child who can't get vaccines to be safe, so I'm going to promote the access to vaccines? Is it because I want women to have autonomy over their bodies to make whatever decision is best for them and their health? We had a state legislator here who had to have a procedure who she didn't realize what that would have been classified as, and she was initially denied access until she made a phone call to the governor. So again, it shouldn't be I know the governor so I can get this procedure. It should be my doctor and I agree that I need this procedure, so I should be able to get it. So knowing that the decisions you make today will affect the decisions you can make tomorrow, and the decisions your children will be able to make tomorrow. That is sometimes what drives people to get involved. And I hope that everybody can say, I've done everything that I can do to optimize my health. I've gone to my appointments. I've had my screenings. Now what can I do to make my community healthier?
And what do you say to people who say, well, my vote doesn't really count? How do we get them connected to the policies that are being brought to the polls at their local level, their state level, and certainly at the federal level?
Absolutely. So, of course, with this being a nonpartisan organization, I definitely want to say everybody has the right to vote however they choose. I think that once you realize that if you have a critical mass of people voting for common sense legislation, that is how you get to the issue of driving those policies. And so even if the person that you voted for does not win, you still go to the person that is representing you and you let your voice be heard. And it's not a one time I show up to the Capitol. It's a relationship. Their assistants that work in their office should know who you are. You should be calling, you should be sending letters, emails, and making sure there's a record. They track every piece of correspondence they get, and they know how they're going to vote. Now, again, are there going to be parties that are going to vote in a certain way based on whatever their party philosophy is? Yes. But if you have a critical mass of people on the ground floor working to make sure their voices are heard, working to make sure candidates that represent their interests are heard, you can affect change. Florida's had a supermajority for now at least 15 years, but you can still affect change. And sometimes it only takes one. And I came of age during Bush v. Gore, so I know that every vote counts. So I make sure to vote in every election. I think it's one of those things that you have to teach kids when they're young. So I make sure my son, and soon to be all three of the kids, will be going to vote with me, so they understand the importance. And then for me, and again for our community, it's a heritage issue for me, because I know that my parents initially were not able to vote. They came of age around the time of the Civil Rights and the Voting Act. So for me, that's heritage, that's legacy. So we make sure that we teach the next generation as well.
Great. And you mentioned the military, very intrigued about that. So the difference between access to care and equitable care, the ability to say, I have an employer, and I have health insurance. Does that mean that I'm going to receive the same care no matter what state, what city, what community I'm in?
Ideally, it should, but unfortunately, we know that's not always the case, and there are a wide variety of factors. So again, I'll talk back about having multiple licenses. So anytime the federal government issues a directive, I will get an email from Maryland saying, this is how we're going to interpret this, and from Kentucky saying, this is how we're going to interpret this. So even though the science is the same, the science does not change just because I drove 400 miles. How it's interpreted, what the local population is used to, what they feel familiar with. And then that also becomes, okay, I have access, I have insurance, but do I have somewhere where I can actually go? Do I have someone who's going to listen to me? Do I have someone who will understand what I'm saying if I don't use the same terms? And that's why it's so important to have a workforce, a healthcare workforce that comes from a variety of backgrounds, so that you can, I'm not going to say interpret, but so that you can understand what the nuances of culture as well.
Mm-hmm. We see in the retail industry, if you go to a fast food restaurant, or you go to some of the big box chain stores, there's a certain standard. The aisles sometimes are the same, the products are the same. In healthcare, what would be a system other than the government system for military? What would be the system for many communities where, as you're well aware, help our audience understand that every community doesn't have the same resources, even in terms of the specialists, maternal health service, pediatricians, primary care, surgeons. So what would it look like if we were to create a system where the distribution of healthcare resources were the same?
I think that while that would be a goal, you'd have to think about different factors. So let's say we're going to have a physician in every specialty within a 100 square mile radius. We're going to have a tertiary hospital academic center within a certain radius. One, you have to look at the areas and the communities. And then let's be frank, are providers, are physicians going to feel comfortable going into some of those areas? And then that goes back to another issue of where healthcare policy comes in. Do we have enough physicians in residency spots to fill the needs of what we need in this country? And that was probably actually my first introduction into health policy from that angle, as well as advocating for more residency spots. I think it's great that we have new medical schools opening, and I look forward to seeing the robust workforce we have. But as you and I know, and that I hope the listeners will know, medical education doesn't stop once you have your MD. You do have to complete a residency to be able to practice in certain specialties. And those numbers are actually capped because they receive money from the federal government. So if we don't increase the number of residency spots, we're going to have a whole lot of MDs that are going to have to find opportunities. And I hope they find residency spots, but the number of residency spots should theoretically match the number of graduates. And then we also have international graduates, which is a welcome to the workforce. It brings, again, a different cultural perspective, and that's an amazing benefit. But if we only have a certain number of residency spots, that limits the number of specialists we can have. It limits the certain number of primary care physicians that are going to go into certain areas. I know there's some states that I probably wouldn't feel comfortable in, and that's me. That has nothing to do with the state. That's just my, I love the South. I love being there. It's a sense of home. So we could write on paper that we're going to require these certain areas to have the providers in the workforce, but it also has to be realistic based on everything that's going on with that community. Ideally, you have people from their own community come back home. That is one area, but then sometimes people don't want to go back home either. So I don't have a good answer. I have thoughts. I have a lot of thoughts, but not necessarily a definitive answer. But part of it is increasing residency spots as well.
And why does our system prioritize treatment over prevention? I mean, it would seem that if we keep people healthy, then we don't spend those healthcare dollars. We spend more than most other developed countries and get less in terms of our outcomes.
You are absolutely right. And I had to learn this from a business person because it made no sense to me, because I made the same argument that you made, that paying for this screening test today will prevent the treatment that costs so much more money down the road that we'll know will be necessary. And I was told we're not looking at down the road, we're looking at this quarter. So it's a difference on when you look at when the money's being expended. So if you have to spend the money on the screening test this quarter, that is the money that they're looking at versus the money that they'll have to spend later, which I think is horrific. But again, I'm not a business person. I always tell people I have the best job in healthcare. I get to interact with my patients. I don't have to figure out any of the front office, back office stuff. So yes, it's a matter of what revenue cycle, how you're looking at the reporting when you're making those numbers. And then that's another reason why healthcare should not be a private entity. It shouldn't be something where you're beholden to shareholders. It should be something where you're doing something for the common good.
And one other area I want to touch on for the audience, Black women and Indigenous women suffer a significantly higher risk during a pregnancy, 3 times as likely to die during a pregnancy. And we don't have good standard health care policy for maternal care or infant care. And again, as an outlier, the United States pales in comparison to other developed and underdeveloped countries in terms of paid leave for mothers and fathers after the birth of a child. What are the greatest impact that we could have as a community to make those changes in our healthcare system?
I think it's threefold. You want to do everything you can to ensure that women in their preconception years are as healthy as they can be, because that's going to reduce some of the risk associated with the stress, the physiological stress of pregnancy. You, again, want to make sure you have great community support. So whether that be a centering method where the women going through the pregnancy are able to go through together and form their own support system, whether that be community resources so that you're not worried about how you're going to provide for this new child. And in conjunction with that, the paid paternal leave, parental, not just paternal, I'm sorry, paid parental leave is necessary, because again, after you have pregnancy, you're not just dealing with having a new baby and all the ways your body changes. There's a lot of mental health that we're still learning a lot about in the postpartum period, which can again affect how you and the baby bond, how you are able to, if you have to return to your job at a certain time, how you're able to show up for there. Because if you're not able to show up for that job, you then lose the job, then you then lose the benefits that we're providing for the health of you and the baby. So it's a big circle, and we have to do a better way. But again, the 3 things I would say are maximizing preconception health, making sure that there's community support, whether it be a pod of pregnant women going through that together, or pregnant persons going through that together, or a more robust community support, and then parental leave as well.
Great. But we're coming close to our allotted time, but I would be remiss if I don't touch on one important topic in terms of making sure that the healthcare policies, decisions that we make in terms of the guidelines for the American people, particularly those who are suffering most from health disparities and unacceptable deaths in their communities, is the research needs to be brought into equity, the funding to do that research, to make sure the decisions we make and the kinds of treatments we recommend for our patients and communities fit to reduce and eliminate health disparities. And then looking at AI, which everyone is on edge about currently. How do we control the data? How do we make sure the algorithms that are being used to so-called, quote unquote, improve healthcare outcomes, how do we know that it's going to be set in such a way that it protects the privacy and also improves the outcomes and healthcare for communities of color who are not possibly part of the data set.
So you touched on another issue which kind of terrifies me. So with AI, in addition to what you just mentioned, and I will address both of those, both privacy and making sure the algorithm isn't having inherent biases or being amplifying biases, also the environmental impact of these AI data centers as well, which we know they are disproportionately affecting communities of color as well. So that's the other part that I wanted to point on. But in terms of the privacy, I don't know anymore, because I actually had a patient recently say, should I be recording the certain information in this app? And I'm like, 2 years ago, 3 years ago, I would have said, absolutely, go ahead and record it. But I don't know who's going to have that information, what procedure, what data breach there might be. So for right now, I'm actually recommending to a certain amount. Sometimes we need to go back to analog and pen and paper to record certain information, whether it be blood pressure, menstrual cycles, whatever that may be. In terms of privacy, again, that comes to advocating. And again, this is how it all ties into policy and using your sphere of influence, making sure that you're talking to your legislators to improve legislation to safeguard our privacy, because it's all of ours. I know we are all getting data breaches about whether it be our passwords, credit card information, but even with those, we can have those reset. We can do a fraud alert. If it's our own health, there's no way to prevent that information once it's out. So definitely working on the front end. And then in terms of bias, working with different tech companies. Right now in San Francisco, they're doing one of their big health tech weeks, and they're trying to discuss these issues. If you only have people that are bringing in one perspective, you're going to miss all those other things. And again, AI, it's a supplement. It should never be the first line. And I think teaching people how to use it will be another big important step in making sure that we're not relying only on that information, because it's only as good as what we put in. And again, if you put biased information out, you're going to get biased. If you put biased information in, you're going to get biased information out.
Great. Well, Medicaid expansion reduced health disparities in the states where it was put in place. Black and brown individuals are less likely to receive the health care and the outcomes in a report by Peter and Peterson research. I think the same thing came out of the Kaiser research analysis. And those states that did not have Medicaid expansion, uninsured people were twice as high to not get the health care that they need, and that affected Black and brown individuals. So we want to make sure that we address those things in terms of making sure folks listen to what's going on in terms of health policy, vote and register, learn what legislation is going to impact your communities, and always come back to our organizations like the Georgia State Medical Association, where you need additional information. We're here and willing and ready, just like the Florida State Medical Association, to come to the grassroots and the churches, the faith-based organizations, and also to the community organizations to share information that's important for you and your health. So as we close, what's one action everyday people can take to influence health policy in their communities that they can take home with them from this podcast and be more positive in terms of improving not only the health of themselves, but their families, their communities, and this nation?
Absolutely. Thank you for that. I would just like to remind everybody that your voice is powerful. Your voice is yours, and make sure you make it heard. So make sure you're registered to vote. Make sure everyone you know is registered to vote, and make sure you're reaching out to your representatives and letting them know what policies that you want passed, what policies you don't, and what they can do to make your life better.
Great. Well, this concludes this podcast. We want to certainly thank the Georgia State Medical Association, our dynamic president, Dr. Burt, who puts this Pulse together. We want to thank our executive director, Kimberly Williams, who helps to organize these podcasts. And certainly, we want to give an overwhelming thanks to our speaker, Dr. Dorothy Russ, who has given us a tremendous amount of information that we can use to improve our health and improve the health of our communities. And there's a lot more that we want to unpack. So I hope we can extend an invitation to you to come back and share more of your insight to this organization and to the community at large.
I'd love to. This was awesome.
Thank you.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.